Hey guys, this is FixerMed. Welcome back to my high-yield hematology and oncology review series for the USMLE Step 1, NBME CBSE, and NBME CAS examinations. In this series, I will be covering the entire system of hematology and oncology in a comprehensive but high-yield manner. This will be part 17 and 18 of my multi-part video series of doing so. Today we will be taking a look at infectious mononucleosis. Without any further delay, let's go ahead and get started on today's content. Today I'd like to open up the presentation by introducing infectious mononucleosis. Infectious mononucleosis is usually caused by Epstein-Barr virus (EBV), but can also be caused by cytomegalovirus (CMV). The virus invades B cells, stimulating the immune system to produce CD8 plus T cells that attack the viral infected B cells. In mononucleosis, these CD8 plus T cells are called atypical lymphocytes or reactive CD8 plus T cells because they respond to the viral infected B cells. Alright, moving on. Next, let's take a look at the clinical presentation and possible causes of misdiagnosis. Primary infection typically occurs in teenagers or young adults, presenting with fever greater than 38 degrees Celsius, lymphadenopathy. Tonsillar exudates, lack of cough can appear similar to bacterial infections. Often misdiagnosed as streptococcal pharyngitis, strep throat. Important to differentiate using Cintor criteria for bacterial versus viral upper respiratory tract infections, URTs. Alright. Moving on. Next, let's take a look at the diagnosis criteria and potential complications. If amoxicillin or penicillin is given to treat Epstein-Barr virus (EBV), it can cause a rash, often mistaken for a beta-lactam allergy. Rash in pre-adolescents receiving beta-lactams likely indicates a true allergy. In adolescents or older patients, a rash warrants a heterophile antibody monospot test to confirm EBV mononucleosis. Following the primary infection, mononucleosis can present as recurrent episodes of extreme fatigue, occurring at intervals separated by months to years. On the picture on the top right, you can see a rash from using penicillin while infected with infectious mononucleosis. On the picture on the bottom right, you can see a maculopapular rash from amoxicillin use during EBV infection.
All right, guys, now that we have covered all of the content, let's go ahead and take a look at some questions to review the knowledge you have gained so far.
A 19-year-old college student presents to the clinic with a 7-day history of fever, sore throat, and swollen glands. She denies having a cough. On examination, her temperature is 38.5 degrees Celsius, and she has tender cervical lymphadenopathy and tonsillar exudates. A rapid streptococcal test is negative, and she was prescribed amoxicillin, after which she developed a widespread rash. Which of the following is the most likely diagnosis?
All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now.
The correct answer is E, infectious mononucleosis. The patient's presentation is classic for infectious mononucleosis, caused primarily by Epstein-Barr virus (EBV). Key features include fever, sore throat, cervical lymphadenopathy, and tonsillar exudates without a cough, aligning with the Centor criteria for differentiating bacterial from viral URTs. The development of a rash after amoxicillin administration is particularly indicative of EBV mononucleosis. This occurs commonly when amoxicillin or penicillin is given during an EBV infection.
All right, let's go ahead and see why the other answer choices are incorrect.
The incorrect choices can be explained as follows. A streptococcal pharyngitis usually presents similarly but was ruled out by a negative rapid strep test. Additionally, a rash from amoxicillin in strep throat would indicate an allergy, not a viral reaction. Viral upper respiratory infection could present with some similar symptoms, but the presence of tender cervical lymphadenopathy, tonsillar exudates, and the specific response to amoxicillin make infectious mononucleosis more likely. An allergic reaction to amoxicillin would typically present with a rash, but not the specific constellation of fever, sore throat, lymphadenopathy, and tonsillar exudates seen in this patient. D. Cytomegalovirus infection can cause a mononucleosis-like syndrome, but it is less common than EBV in this age group and does not typically result in a rash following amoxicillin administration.
All right, now that we have covered this question, let's move on to look at the next question.
A 17-year-old high school student presents to the clinic with a 5-day history of fever, sore throat, and swollen glands. She denies having a cough. On examination, her temperature is 38.3 degrees Celsius. She has tender cervical lymphadenopathy and tonsillar exudates. The rapid streptococcal test is negative, and she was prescribed amoxicillin, after which she developed a widespread rash. Which of the following is the most likely diagnosis?
All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now.
The correct answer is D. Infectious mononucleosis. The clinical presentation of fever, sore throat, tender cervical lymphadenopathy, and tonsillar exudates without a cough is typical for infectious mononucleosis, commonly caused by Epstein-Barr virus (EBV). The negative rapid streptococcal test rules out streptococcal pharyngitis, and the development of a rash following the administration of amoxicillin is a hallmark of EBV infection, distinguishing it from other conditions.
All right, let's go ahead and see why the other answer choices are incorrect.
The incorrect choices can be explained as follows. A bacterial pharyngitis often presents similarly but was ruled out by the negative rapid streptococcal test. Moreover, a rash due to bacterial infection and amoxicillin would indicate an allergy, not a viral reaction. Viral upper respiratory infection can present with similar symptoms but does not usually include the specific combination of fever, tender lymphadenopathy, and tonsillar exudates seen here. The rash also points to EBV. An allergic reaction to amoxicillin would present with a rash, but would not explain the constellation of symptoms including fever, sore throat, lymphadenopathy, and tonsillar exudates. Simplex virus infection can cause pharyngitis, but does not typically present with the described combination of symptoms and is not associated with a widespread rash following amoxicillin administration.
All right, now that we have covered this question, let's move on to look at the next question.
A 20-year-old college student presents to the clinic with a 7-day history of fever, sore throat, and swollen glands. She was initially diagnosed with streptococcal pharyngitis and prescribed amoxicillin, but she developed a widespread rash shortly after starting the medication. On examination, she has tender cervical lymphadenopathy and tonsillar exudates. A rapid streptococcal test is negative. Which of the following is the most appropriate next step in diagnosis?
All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now.
The correct answer is B. Perform a monospot test. Performing a monospot test is the most appropriate next step. The patient's clinical presentation, fever, sore throat, tender lymphadenopathy, and tonsillar exudates, and the development of a rash following amoxicillin administration are classic signs of infectious mononucleosis, commonly caused by Epstein-Barr virus EBV. A monospot test detects heterophile antibodies and is used to confirm the diagnosis of EBV mononucleosis.
All right, let's go ahead and see why the other answer choices are incorrect.
Incorrect choices can be explained as follows. A repeating the rapid streptococcal test is unnecessary given the initial negative result and the presence of symptoms more indicative of viral etiology. Checking for a penicillin allergy is not the next step because the rash is more likely due to the EBV infection than an allergic reaction to amoxicillin. Conducting a throat culture may help diagnose bacterial infections, but is not the most appropriate next step, given the high suspicion of EBV mononucleosis based on symptoms and rash development. Testing for cytomegalovirus CMV could be considered if EBV is ruled out, but CMV is less common and the clinical presentation is more typical of EBV. The monospot test is a more appropriate initial diagnostic step.
All right, guys, that is all I have for today. Be sure to leave a like if you found this video useful, a dislike if you did not find this video useful, and consider subscribing for more content like this in the future. If you would like to check out more review material, be sure to check out my other USMLE/NBME playlists on the channel. If you have any questions, comments, concerns, or suggestions you would like to make, please be sure to write them up and submit them in the comment section below. This is FixerMed signing off. Be sure to have a great day or great night, and as always, good luck studying.